So we are basically opening the session for open discussions, so you can also raise questions to the other speakers.
Thank you. I'm a bit concerned about this discussion because it seems as if we're not going to be the driving force to set the rules and regulations to inform the law. We're going to leave it to case law by lawyers. We can't allow that. They should not be setting the rules. We should be driving the rules.
Yeah.
There's a question to Dr. Surya about the camps. I know that you draw quite a lot of patients to the camps, but I know at times people have got difficulty in traveling to move around. They don't have vehicles, or the transport is expensive, and there are issues with architectural barriers. How do you overcome all that?
I think you must attend one of my camps. I think it is the most systematic, well-coordinated camp you will see. People wonder what. Now, we have made a complete model, which is now we call Maharashtra model of total epilepsy care for rural India. There are more than 200 people are involved for more than 1 month to make the camp successful, and understand that I have camp every month. So now 19th May and my next camp is 23rd of June. So now what government do is, the government of India has sanctioned 4.4 lakh rupees for 1 day camp, which is highest amount of money for any 1 day camp in India. I spend about 2 lakh rupees extra on that because I provide free EEG and free medicines also. So out of this 4.4 lakh, 2.5 lakh rupees is only, that means about 60% is for medicine to each and every patient. Every patient gets 3 months medicine free. Those who desire, they get EEG free. Those who require, they get CT and MRI free. Now that's one part. So when you have such camp, there are people who are waiting. The people actually are waiting that when our camp is next, they find out through these telemedicine services what we have, and they come to the camp. But what government do is, government has a networking. Even a small town where there are 50 families are living. So we have school health worker. The duty and the patients are being identified from the schools, that these are the patients with epilepsy. So the moment there is a camp, those are the patient comes in the government ambulances. So government provide the vehicle to them. Each patient, there are 10 or 12 patients, 20 patients, comes in an ambulance from one particular area which covers about 20 kilometers, 50 kilometers. So my camp in one district rotates around 200 kilometers of yard. So the biggest problem was follow-up of these patients. And that is what I have addressed now. So this year, what we are doing is, we are starting regional epilepsy center. So there will be 10 centers in Maharashtra, which will be, because Maharashtra has got 8 circles. Each circle will have about 4 districts, and each circle will cover about 300 kilometers. And therefore, there will be a once a week neurologist, the EEG machine, CT MRI, data operator, EEG technician, social worker, and the nurse. So that's what will be there in each regional epilepsy center. So that will be something where there will be a follow-up medicines. So there will be a regular supply of the medicine even after the camp throughout the year. So I know that this was difficult, but this I have been able to reach up to this now after so many camps. So initial camps were disaster. I was thinking what is to be done. But gradually and slowly, over a period of time, we are able to plug it out. That's how initial first phase, we did not have therapists. I realized that because in rural India, there are a lot of home deliveries. Children are developed at home. And therefore, there are a lot of difficult labor, delayed cry, giving rise to the mental retardation, disability with epilepsy. So I thought that we need to tackle this because the patients are coming, they're not able to walk, they're not able to talk, they're handicapped. Only medicine alone will not help. So we added in second phase 2 physio, 2 OT, 2 ST. And then they're coming voluntary. We give them a small remuneration, but that's not enough. Government pays that. But they're coming. So we have plugged it. I think it's worth, and whenever you are in India, at least attending one of the camps. It's a different aura. Thank you.
I mean, that's obviously fascinating. But what I was just, probably I did not express myself properly. What I was referring to is not necessarily epilepsy, but I'm just referring to people who have got severe disabilities, like who have got severe disabilities, who are not able to travel, and so having a camp in one place, to expect them to come to that place, I was just wondering if the model should not be to go to their place. So.
Yeah. Paolo, c'era prima...
I have a question. I have a question to the audience. For the last 10 minutes, 15 minutes, someone has an idea how we could do together for the following of this conference?
There was a question there before. Yeah.
I just want to come back a little bit with the topic issue. So because like you said, you have to start from the problems we need. And in Chile, for example, there's a program we don't have many neurologists specialists, and there is a few hospitals they have a specialist. And so now the telerehabilitation is a new program. There is a primary SNRs where there is not a specialist. There's general doctors, and all the strokes sometimes arrive there, and they don't know if they make a thrombolysis or do something. And now the program is you can connect with a specialist to watch what's happened, and they make a team with the doctors there. So now it's a project with that, the law can go on support to have this telemedicine to support the action in that. So I want just to ask if there is a project in Chile about, because the necessary in Chile is we don't have a lot of geriatrics and neurologists doctors, and I think the telemedicine is one of the best options to decide what to do in the emergency and stuff like that.
Yeah, thank you. Thank you. It's very important what you write. But now, according with Paolo, the question is open not for all the things, but just to raise the question: what is the method to proceed after the conference?
Suggestion is the questionnaire by your
Yeah.
work, yeah, that's one. Number two, obviously medical legal issues or implications. So we should have a lawyer, yeah, or in the next meeting to just tell us about BOLEM and all the like us is the Malaysian Medical Council. What is their stance on or view on the rollout of the legal implications of telehealth. And then the third one is maybe we go by region, like low resource, middle resource, and high resource country. Every subcontinent present what telehealth policies that's existing, or whatever issues or challenges, and what is their next plan. Incidentally, in Malaysia, we already have this telehealth policy, and the committee is revamping it, just cancelling the previous policy because it's not relevant, or the medical legal implications. And the concerns by the Malaysian Medical Council, if we roll out this, number one is, are we going to lose our jobs? Yeah. So the last conference, ISCOS conference in Sydney that I attended, the future is all about us being data analyzers. So yes, the clients can have wearable devices, they can have a lot of data, but who's going to interpret it? So that's going to be our role. So we cut the traveling, It's the expertise, which I think India has done a very good job. Yeah, the expertise. So we can appreciate in Korea, that's the future. But at the moment, I think the different countries, different resources is the key here, the key theme. Thanks.
So your proposal is to put all these things in the survey? In the survey, from to be practical, yes.
Actually, I proposed last evening to Professor Tavlo, and he's running from me. I said, write down the proceeding of this meeting, because you got world coming here. Everybody has their own issues, their own benefit. If you can bring them together, present this to WHO and UN, and ask them to give a uniform platform of tele-rehabilitation for the world. So today, if WHO gives a policy all over the world, it has been heard. Nobody else otherwise follows it. So I think most important thing is, I'm sure everybody who has talked here and those who have come here also may not have talked about, they can put their experiences, and you appoint somebody to have the proceeding of first Teleneurorehabilitation meeting, and outcomes, challenges can be written by somebody, and then this can be forwarded to all the government authorities of all the countries along with UN and WHO, and then it will really make an impact. May not be in 1 year, but maybe another 5 years, 10 years, and you will come out with a uniform baseline policies across the globe.
Yeah. Other proposal? No, just putting together the things we can, I don't know if it's too ambitious, but starting from this group that discussed a lot during these 2 days, we can create an expert group that is aimed to define a survey as the first action, putting all the information and gathered all the information across the countries. And the second step could be define and focus the problem and the proposal to be part of the action of the local or regional societies, scientific society that can take care about the definition of guidelines and all the issues that we raised.
If I may, I'd like to represent the International Association of Logopedics, this International Association of Speech and Language Therapists, in essence. We've already had some chats with people here and through email, and we've decided that we will take forward bringing together a lot of the bits that we've heard here to have a more coherent approach in speech and language therapy. I wonder whether each of the professional groups might like to do that, so that we can look at what are the important issues across the globe, so that they can be brought together in a coherent document that we've heard about.
Yeah, this is a spirit I think that we can...
Yes, just a short point. I was just thinking that in addition to WHO and UN, we should include the World Bank, because they're the ones who very often finance the WHO, and they run a lot of programs.
WHO, I just mentioned the WHO in my presentation, but it's very important to connect with the WHO, especially with the DAR, Disability and Rehabilitation Commission, and because now they want to go on in the agenda of 2030. That will be the agenda of the practical application of the action. And so we should try to put this aspect in the next meeting in July. So I don't know if we will be there, but Matilde for sure, and as the European and International Association, we have the link that is Charlotte Kickens that can take care about this. And so this could be a practical action. And there are all the speech and language therapist organization, physiotherapist organization, and so on. So it's a converging point. But from our side, we have to think about, of course, to the guidelines across all the professionals in order to push for that. So our parallel action, not alternative. And we ought to set up a group for the survey. So we ought to define the items to submit to the survey. Yeah, so from the practical point of view, of course, we need the mailing list and the contact to set up the group together. No, just to be practical, not... Other suggestion?
Well, if I may suggest something, or let's say summarize. In most of the talks we have heard that the cost of the telerehabilitation would be lower and so on. Well, from my perspective, I think for the same costs, we could provide services to larger population, and this should be the goal. And if we provide services to larger population, I think we expect that the national healthcare will probably include this kind of service into the medical services. Or do we expect that the private insurance companies will enter this field?
It may not be practical in developing countries, where the cost will come as a very, very important factor.
Well, and there is one sub-question which is probably different in different countries. How much are patients willing to pay for the service?